Yeah, you talk a little bit about insurance
Mm-hmm.
and kind of how that can be helpful, but there's also this piece of things where you have government intervention, whether we're talking about federal or state, both, and the insurance industry, which are turning into more and more of the drivers behind what patients can access. And we're seeing this surge of direct primary care,
Mm-hmm.
certainly here in Maine,
Mm-hmm.
practices, and your practice is a little outside the box.
Mm-hmm.
Can you speak to direct primary care and the practices that may or may not look like yours, maybe a little bit different, but moving outside of that perhaps traditional model
Mm-hmm.
to something different that is patient-centered, because that's what you guys are all about,
Yep.
is this patient-centered. How do we go from where we are to a truly patient-centered model?
So I'm gonna answer that question, but in three parts.
Okay.
Okay. So
Well, it's a big question.
it is. So Maine's it's a fascinating state because as CMO for the Helios Group, we have about under LOI, we have 9 offices currently. We have a couple under development in 4 different states, and so the markets can vary a lot, and the just the social habits can vary a lot depending on the states and the markets that you're in. But Maine is a really interesting state because insofar as you want to think of things as being covered, I'm going to use the words covered with parentheses.
Sure.
From a health insurance perspective, anyone who has health insurance has the perceived ability to access care. Okay. And
Yeah, perceived. I think that's a really important word, perceived.
it's really important. It's perceived because if a lot of the benefits in the state, I would say, are considered ghost benefits. So what we've seen over the last decade, let's just take chiropractic for a second. I will come
sure.
back to direct primary care on this, but one of the most common things that we see in today's age in the healthcare space is that a patient might have a $50 or $75 copay now to see a specialist such as a chiropractor. And most of the time, a chiropractic service with most major payers is going to be less than the copay is. And so the patients, on top of these ever-increasing premiums that we're seeing that are financially crippling our country, we're now seeing patients also bear the responsibility for the entirety of their care. And so unless you're in a major injury or in a major hospital stay or require some kind of medication that actually is truly expensive, not actually is truly expensive to make.
Yes.
Not costs a lot.
Yeah.
There is a
But
difference.
actually
is
yes.
exquisitely expensive to make. Then the majority of the majority of the financial responsibility is always on the patient. And so in specialty care, we haven't quite been able to navigate our way around that. The physical therapists are, I'd say, I think I heard a statistic from one of the local physical therapy schools that 90% of new graduates are going into cash-driven systems because they just cannot make the sources.
That's a remarkable statistic.
It's a
90%
terrifying statistic.
into a cash-based. Holy
Because
cow, that's massive.
The sources and the uses of what you can reasonably generate on a per hour basis, seeing patients in a patient-centered way in the state of Maine with where our reimbursement is at,
Yes.
does not line up with the requirements of paying your rent, paying yourself something that can cover your student loans, paying your admin staff. It doesn't work.
Yep.
And a lot of that is because of the same reasons why the medical specialists all rolled up about 20 years ago, as they were experiencing the same financial pinch. And so because most chiropractors, physical therapists, acupuncturists, occupational therapists, anyone who's independent, they have no realistic bargaining capacity to negotiate with insurance companies to have even just a cost of living adjustment.
Sure.
Most of the major payers haven't. As I can state that on behalf of the Chiropractic Association, there hasn't been a major payer increase since before 2010.
Hasn't been a major payer increase since before 2010, but then we also have this phenomenon in Maine where a third of our population is on Maine care.
Absolutely.
And so then you're negotiating with the government, and I'm sorry, but that's probably, that's even a tougher lift because you're trying to get the legislature to vote you, appropriate payment.
Yep. So Maine care is exceedingly difficult to work with because the reimbursement is below Medicare, which is considered kind of the financial floor of the model. And there's just a lot of interactive behaviors with that patient population that makes it very difficult for you to wear your altruistic hat. So my brothers who participated with Main Care for a long time because they felt that it was important to help that population. Sure. They were the first office for that you would get to from Washington County.
Wow.
Had to go all the way through Washington County, through Ellsworth, all the way to Penobscot County to get to them. And patients that were traveling from Washington County were getting reimbursed for getting travel reimbursement that was greater than the provider was getting to render the service.
Wow.
And, so again, it's one of those scenarios where it's important to help people. We got into this business to be of service, but when we're in a position where we're actively losing money to see these populations, you can't do that.
Right.
It is a business. It's not a charity. We have to be able to cover our life expenses to be able to perform the service. And ultimately, that's why you're seeing more and more providers have to pull out of network of these systems. It's just not financially feasible.
No, I mean, and the fact is that when folks do take Main Care, I mean, it is a fact that insurance payments are subsidizing, insurance or cash payees are subsidizing that Main Care payment because the reimbursement rate is so low.
Yep.
That is how the system currently is constructed.
Yep. So to come back to direct primary care. So, in the primary care model, because of this erosion of compensation on a fee-for-service model, we reached a point where any kind of infrastructure system, so a large primary care collaboration, because the costs to work with insurance, in addition to the reducing reimbursement, you have all of these hurdles you have to go to just do your job. You have prior authorizations, which I believe now is estimated to take up almost 30% of a primary care provider's time, is just sitting on the phone trying to get this medication approved.
That bureaucracy, just trying to get approved. The treatment that you know best, you know what the patient needs, but you have to sit there and jump through these hoops to get it approved so it can be paid for.
So I'm going to placehold that.
Yeah.
That's a real problem that we have in this space. But because the primary care model would require these providers to have panels of 2,000, 2,500, 3,000 people, and the math would work out that these providers would have to see a patient every 8 to 10 minutes just to be able to generate the dollars to be able to keep the business moving. It just doesn't work. We can't have a meaningful conversation where I go through your entire health history, every medication you're on, do a full systems review, and come up with a collaborative, comprehensive plan to help you in 8 minutes.
No.
It just doesn't work. And so the primary care model, the direct primary care model, was kind of born out of necessity from that, where the providers that were really passionate about their patients, the patients know. They know when you actually care. A lot of them were like, I cannot work this job the way it's meant to be done within these parameters, so I'm not going to.
Yeah.
And so we've seen a surge of direct primary care practices within Maine where these providers can act independently, have a panel of 250 to 500 people, anywhere between a tenth and a fourth of what they had to manage within the insurance model. And just be on a subscription basis. And, they're there when you need them and they're not when you don't. And when you have those kinds of models, you can now bypass all of the insurance hoops required to get that reimbursement. If I were to be your primary care provider, which I am not, but just from a discussion purpose, if you had an issue with what you were feeling, in a fee-for-service model, you have to be in my office. We can't talk on the phone. You have to be in the office. I have to check your vitals. I have to check your blood pressure. I have to do all of these.
To jump through all of the hoops
just
that are
to get the reduced
required
reimbursement.
for the reimbursement.
And so as opposed to us just having a conversation, hey, what's going on? Or whether that's text message or cell phone or all of the technology that we have, I'm feeling this way. And you go through those symptoms and 80 to 90% of the time that these issues can be resolved just by communicating as humans, as opposed to necessarily looking at you. And certainly the cases that require exams are a little more alarming. No, I need you to be in here. Let's check your vitals, do some rapid testing. Let's see what's going on here, versus my child's having an earache. What do I do here? What are the first options? And being able to give patients options to help them navigate the issues with early intervention versus letting it marinate while we're waiting for that appointment. And now all of a sudden we're in a far worse place than we would be. We're avoiding unnecessary cost. We're solving the patient's problems with early intervention, resulting in lower care, lower cost of care.
Well, and I think that's important to note, because when you're talking about, these are subscription service usually is the fee model. And so folks go like, oh, maybe you're paying for insurance at the same time just to have that backup, and then subscription on top of it. But if you weigh in the balance, the unavailability of the traditional and then, a couple visits to urgent care, the math suddenly starts to make sense.
Oh, 100%. I mean, 2 urgent care visits, you're breaking even for the year.
Right
and
there.
If you have, I have 4 children. You have you have similar sized family, 5.
Yes,
right? 5.
5.
Yeah. And the inevitability of
Somebody
having to make
is
it to an
always
urgent
doing
care.
something
Yes.
dumb.
Yeah. It's not if, it's just when. And so the math works out for a lot of people for you to be able to say, okay, I'm going to budget this resource towards making sure that my medical needs on a non-emergency room basis, like you break your femur, you need to have a reduction. That's a completely different discussion. But
Totally.
the 99% of the things that we need can be managed in a clean access, fastidious method at a very manageable cost. And I think that's just why we're seeing such a bloom of this particular model. And I'm fully in support of that. We have urgent care services in our Cape Integrative Health location, but I still use a DBC for my kids because it's just easier.
Absolutely.
It's just easier. A text message basis. We love our provider, very accessible, and you get your problem addressed quickly and reasonably.